So first of all, I want to really thank you all for inviting me to this. I have checked out some of the presentations previously, and I hope that I can meet the standard that has been that you have formerly had. I also noticed that you have had a couple of presentations on FOP, one by Ed Schau and one by Zvi Grunwald. So I am going to cover a little bit of the background of FOP, but if you want a much more extensive background on FOP per se and or general anesthetic with FOP, please have a look at those previous presentations that you actually have in your records. So without much ado then, what I am going to present then today is the mostly the oral health implications and treatment approaches, so that the focus of my presentation today is really, I would call it safety, especially from the perspective of medical dental intervention. I'm just trying to see. Okay, so the FOP, the gene was actually discovered in 2006 by Dr. Eileen Shaw and Dr. Fred Kaplan. And it was identified as the escape from prison of bone. So the mutation in the gene, the ACVR1 gene, essentially translates into the BMP, or the bone metabolic pathway protein, in which an amino acid arginine has been replaced by histidine. The mutation changes the sensitivity of the BMP receptor, causing a different signal to enter the cell and fibroblasts to behave like osteoblasts. So you result in the stimulation of HO, or heterotopic process. So what then is FOP? Essentially, it's a disorder with skeletal muscle and connective tissue that ends up being gradually replaced by ossified tissue, by bone. That leads to the bone formation outside the skeleton, or what we call extraskeletal or heterotopic bone. And of course, then this is going to restrict movement dramatically. The process is noticeable in early childhood. It starts with the neck and shoulders and moves down the body and into the limbs. And fortunately, the last joint to be involved in many instances, not all, by any stretch of the imagination, is the temporomandibular joint, luckily so. Most individuals with FOP are born with abnormal toes, which is the hallux valgus, which can certainly be helpful in making a diagnosis. And so the clinical diagnosis can certainly be made from evaluation of the toes. And what's interesting is in Brazil, they've actually come up with a law that says that every infant needs to have their toes evaluated for the hallux valgus. The flare-ups can last for several days to months, and often result in permanent bone growth in the injured area. What's interesting with respect to oral health and flare-ups is that it's really important that dental treatment not be done for about 3 months after you've had a flare. FOP is almost always genetic in manner, and it is the ACVR1 gene, as I said, which is inherited in an autosomal dominant manner. And it's extremely rare, depending on who you read, in about 1 to 1.6 million individuals. So there are about 800 people that have so far been diagnosed in the world. I've been fortunate enough to attend a number of family gatherings and probably have seen 200 of those individuals in different areas of the globe. So as I said, it begins with in areas of the neck, the back, with bony protuberances that can be quite painful. And it progresses to gradual skeletogenesis, where the whole body essentially becomes encased in its own bony skeleton. So some of the issues or some of the things that have been identified as triggers for the HCVR1 gene are inflammation, hypoxia, possibly just innate immunity. So what this slide is representing essentially is Dr. Kaplan talks about you do not want to wake up the sleeping bear. So if you've got that nice little bear in the upper left-hand corner, you don't want to necessarily activate that ACVR1 gene because then it becomes quite a problem. Now, I do want to briefly speak about tin soldiers because tin soldiers, which was started in South Africa, was essentially the mandate for tin soldiers was to search for the undiagnosed. If the prevalence is 1 in a million or 1 in 1.6, and we only have so far 800 individuals in the world, you can see that there are huge numbers of individuals that have yet to be undiagnosed. So tin soldiers came up with the mission to search for the undiagnosed. Now, as what's interesting, as they began to seek, and they have now found a number of individuals that previously had not been diagnosed. What has happened is that a number of musculoskeletal conditions were identified. And so they have continued and expanded their mission now and will be focusing on other rare musculoskeletal abnormalities as well and searching for the undiagnosed in those. And the principal aspect of their mission is to make sure that we can facilitate pathways to care once individuals have been diagnosed. So I did want to identify that, and they have some excellent educational material that can be used to help individuals with diagnosis. Now, I think what is absolutely essential in FOP is the importance of early diagnosis. And this is a young girl that from Poland, actually. And she had a protuberance on her head when she was not even 1 year of age. And the surgeons went ahead and biopsied it and removed it. And one of the problems with FOP is as soon as you go in surgically to remove it, it comes back in spades. And so they removed it a second time. And then what they ended up doing is, because of the pathology, which was not necessarily clear, it just showed some dysplasia, is they put her onto chemotherapeutic drugs. So she was on chemotherapy for over a year before she actually got diagnosed. So almost all of her issues are iatrogenic in nature and not from the actual disorder, which is FOP. And if you look at her toes, you can see that it would have been a relatively simple thing to actually look at her toes, identify FOP, get the appropriate genetic screening, and a lot of those issues would not have occurred for her. So it's extremely sad. And unfortunately, it's not unusual that the diagnosis is not made early. In fact, only this week, I received a phone call from an individual here in Ontario, and her 11-year-old son, after a bicycle accident, had a lesion, and his shoulder had gone into, had developed a HO, and only at 11 has he now been diagnosed with FOP. So had he had any kind of issues, say, for example, dental earlier on, that may have been quite serious for him long term. And I'll probably go into a little bit more of detail related to that as we come along. Just to get the, because I know medical individuals and dental individuals really like evidence and papers on these topics. There have been a number of reports in dentistry and in medicine with respect to oral health. And oral health, most of them are case reports. There's only really been one paper that looked at about 42 cases that was done by Dr. Kaplan and his team. And really, they did not find any specific phenotype that is ideally connected with FOP. So essentially, FOP doesn't result in any specific problems, but is much more related to the impact of the FOP on the development of the jaws and the development. And so that's where we need to concentrate. And so it's much more important to look at every individual and see what it is that they represent. And so I'm going to go through a lot of cases for you so you can see a lot of variations with relationship to what happens with the oral health of FOP. But before I get into that, and I think it's really important to just highlight when I'm talking about health, what I'm actually speaking to. So for me, the definition of health is a support system that empowers a person to live fully and well as they are. It's not a Band-Aid solution to try and fix a person. And with FOP, if we want to fix them, we are way out of luck because there's really no fixing individuals. And so supporting them in what they are and how they are becomes very, very important as practitioners. Health really is a resource for living and should not be treated as an object. And it is a multidimensional, dynamic concept that can be described as the inclusion and balancing of an individual's social, emotional, spiritual, and mental status. I think too often as medical professionals, we forget this aspect of what health is. And so I think cultivating this wellness paradigm is important, especially when we're working with individuals with a disorder such as FOP. I will get onto the bandwagon here from a dental perspective and try and reinforce the concept that truthfully, the mouth is the gateway to the body and therefore overall health. And I really would encourage all individuals not to forget about looking at the mouth when we are evaluating them. And especially with FOP, I see it way too often that the mouth actually is ignored, and yet it can essentially be one of the most devastating issues with respect to quality of life in this population group. And interestingly, the mouth is one of the areas where we do have some control over, and yet in FOP, very often, that control is taken away. Now, when I do evaluate individuals with any oral health disorder, I use the ICF, or the International Classification of Functioning, as a methodology for evaluating it, which is really a functional assessment rather than a medical assessment. So I'm not using a medical pathological assessment in evaluation, but rather a functional assessment, which actually looks at an individual with respect to a number of domains in which they continue to live. So it's the interactions between those components, between those domains, that becomes really important. And so if we look at those domains as being the body structure and function, which is essentially the structure of the body, the joint function, how the individual, how that impacts their ability to be active in society, whether that impacts how they participate, and how the combination of those is impacted by personal and environmental factors. And it's interesting, my daughter, who just had a baby, went to try and get her passport for the baby this morning. And she went to a government office and she phoned me and she says she cannot believe how she was not able to get to where she was going without going downstairs. And there were stairs to the elevator. So there's nowhere from the parking lot to the elevator that didn't have stairs. So she had a 2-month-old baby with and so she said to me, I cannot imagine what it must be like to have a mobility restriction or to be in a wheelchair. And so the barrier to care is not the individuals, it is society and how society has put that onto individuals. So I just wanted to bring that to your attention so that we can be aware of it. So when we're looking at dental issues, there are many different things that we begin to have a look at. We look at self-help to get mobility restrictions in their joints, and they cannot do self-help skills like brushing their teeth, whether there is complete closure and they can't eat, whether you have infection, where we can alleviate some of their issues related to eating. How does that impact their airway? And what happens if you get cavities and even need things like braces? So I'm going to be covering some of these issues. So here you see a number of slides. And the top left-hand picture, you can see now, I know you're not dentists, but I'm going to give you a little bit of dentalese, if you will, so that you can begin to see the difference when you're having a look at the mouth with respect to what we hope and what we don't want to do in terms of individuals with FOP. So the top guy on the top left-hand side, you'll see how the top teeth are covering the bottom teeth, and essentially the top teeth look like they're pointing down the back of his throat. That's what we call a class 2 division 2 malocclusion. And the person in the middle, on the other hand, has a space between his front teeth and his bottom teeth. Now imagine if each of those individuals became fully enclosed in their jaw, which one is going to have an easier time and a better quality of life with respect to being able to eat. Now, if you have a look at some of the bottom pictures, those lesions result in really severe mobility restrictions where the head doesn't move, the body doesn't move, the shoulders don't move. And oftentimes it's impossible to get those individuals even into an X-ray so that you can get a full X-ray to determine what's going on in their head and neck area. And so it becomes very much more difficult to do appropriate diagnoses. This really is what I was talking about in environmental factors and how they can be barriers or facilitators. And individuals with FOP, with their mobility restrictions, are going to have a huge number of barriers put into their way with respect to being able to facilitate functioning within a normal environment. So just to be aware of that and be, I think, is really important. So ultimately, the most important piece that we need to think about with respect to oral care is, first, do no harm. So with dental or oral health invasive treatments, you can inflict or you can be a trigger to a problem or a HO flare-up. And the main objective is that we want to reconstruct individuals without causing a flare-up, without causing eventual temporomaxillary ankylosis. So that is the main goal, and I'll talk a little bit about what we do with respect to that, and I'll also talk a little bit about some of the issues related to TMJ. So because most individuals visit dentists on a relatively regular basis, so they'll see us more commonly or more often than they might see you. And in individuals with FOP, the recommendation is they get seen every 3 months. We can actually do a certain baseline testing for them with respect to what is happening for them. So some of the baseline testing we want to do is neck mobility. Where is that? What's happening with their body posture? How is their breathing? And we evaluate their breathing automatically every time with pulse oximetry. And what is the maximum opening? So if we notice that there's any change in those metrics, we can bring that attention to the primary care physician yourselves and let you know that something may be happening with these individuals. So I think it's important if you do have a patient with FOP that you encourage your oral health practitioner to be aware of some of these issues and let you know if any of those are occurring. So because oral health is inextricably connected to a person's overall physical, emotional, and psychological well-being, it's essential for us to really continue to try and maintain the best oral health possible. Now, one of the things that I have noticed over time is that the mouth tends to disappear into, I don't know, it seems as if many individuals, as they move through a crisis, say of a joint or a body HO or a flare, that they forget that they actually have a mouth and they don't continue to actually see us on what the recommended basis is, the 3 months. And then by the time we see the individual, the crisis is quite severe and it's much harder to then work with them. So quality of life with respect to individuals in terms of their oral health becomes a really important piece. And Lisa Friedlander, a colleague in France, did a QOL life evaluation of individuals with rare diseases. And we actually just completed when we were in South Africa, we saw about 25 patients. And we did evaluations of their QOL, and we're going to be writing that up shortly. And some of the issues that we picked up in South Africa with the patients in South Africa were a little different to what I've picked up in other countries. With respect to that slide on the right, I'm going to be covering it later in a little bit more detail. So what are the key questions that we have for individuals with FOP? So the key things that we're looking at from a perspective of oral health are infection, whether an individual has submandibular pain or flares in the submandibular underneath the jaw area, whether they end up having the locking or ankylosis of the jaw. Is orthodontics something that we recommend? Is that an important part of an individual's health? When do we recommend the removal of wisdom teeth, and do we recommend it? What do we do about treatment of cavities? And are there options that we can do with individuals so that we can minimize the invasivity of what it is that happens? And part of oral health is our ability to eat and swallow as well. So we shouldn't forget about the impact of eating and swallowing. And I would encourage any of you to put your head into a position that it is immobile, slightly back, and notice what happens to your swallow reflex when you have immobility of your neck and it's in an abnormal position. Now, if you're swallowing like that 5,000 times a day, imagine the impact that it has on the rest of your body. So eating and swallowing is something that we need to be evaluating on an ongoing basis. So let's take a look at a number of issues now. So with respect to infection, now I understand that you're not dentists, so you may not be familiar with some of the X-rays that I'm showing you, but this is essentially a panoramic radiograph, and you can see where I have the indicator. This is an individual who has a frank infection of the tooth in this area. It's the lower left molar. And obviously, this person has had fillings done. These white things are fillings that have been done in the past. Now, what's interesting is that in order to do these fillings in the bottom of the jaw here, the kind of anesthesia that is required is an anesthetic that could be a trigger for an HO to occur in the temporomandibular joint area. And so a dentist who would have been unaware that this individual had FOP and did these fillings could very well have triggered an HO and caused this individual to be fully ankylosed. This is a major problem, and why it is so important for dentists to be aware of FOP, to be aware of the issues, and to minimize. And what's so important about the best treatment for dentistry is no treatment whatsoever. So the best treatment for holes is not to get them in the first place. So here you have an individual, and the panoramic radiograph that you're seeing on the top right-hand side there is indicative that you can see that she's got a full lower dentition, and that is really quite healthy. She's had one cavity down in this area over here that's been filled, and in the top she's had a root canal, a crown, and nothing really extensive in her jaw. She was complaining about pain in the right area of her jaw, and went to the dentist and was placed on an antibiotic. She went to her primary care physician, was placed on an antibiotic because the pain did not go away. And it was only after about 6 weeks that she ended up contacting both myself and Dr. Kaplan. And after looking at her X-ray, looking at it, we actually thought that she might have had a flare. So had she been treated appropriately right at the get-go, and not made the assumption that the infection was of odontogenic was not odontogenic in its origin, then she may not have had some of the issues that she had. So after discussion with Dr. Kaplan, actually, we have shifted the guidelines somewhat and have made the recommendation that unless otherwise identified, make the assumption that it is a flare and treat it as a flare. So the way that Dr. Kaplan talks about it is, if you have a fire, you don't wait for the fire engine to come and put the fire out. If you have a hose pipe available, you're going to use the hose pipe. And so the recommendation now is to basically carry prednisone in your pocket and start it immediately, and then evaluate to see if you have an infection. If you have an infection, of course, you want to treat the infection, because infection is one of those issues that can trigger an FOP flare. So infection, anoxia, pressure, unusual pressure, a myositis, these can all result in a flare. It doesn't necessarily mean that it has to have that for a flare to occur, but we should assume it's a flare, and until otherwise proven, not odontogenic in nature, and treat appropriately. So the impact on individuals in terms of odontogenic flares, in terms of HO, here you have an individual who actually is completely immobile. She cannot move her head off the bed. She's got a full HO in this area. So if you had a look at this initially, you may think that this is I'm going to go back to that. You may think that this is some kind of an odontogenic infection, but this is actually HO that has resulted in complete neck and head immobility. And she also has complete ankylosis, and we'll talk a little bit about what we do in those cases. Let's have a look at another radiograph that is interesting. So I'm going to point out some of the issues with this radiograph that you might not otherwise be able to discern. So this is a radiograph of an individual in what we would call the mixed dentition stage. So that mixed dentition is you've got the permanent teeth in the front, and you've got the permanent teeth at the back, and all these teeth over here are what we call your primary teeth. Now, if you have a look at these teeth on this side over here, where I have the indicator, you can see this dark area underneath the white area. So the white area is enamel, that dark area is the dentine, and then this area that's black is your pulpal area. Now, there's a black area underneath that, which is active decay. So we have an individual, if you have a look at this in a little bit more detail, that has actually extensive dental decay, and that becomes a major issue. So she had a lot of swelling, a lot of pain related to those areas. And the concern is that it could result in a flare, which results then in HO presentation. She did not have, as far as we knew, any breathing issues. And she still had a relative ability to open her mouth. So when we have a look at the ability to open the mouth, we normally classify it in a number of ways. And the easiest way to do that is a finger width. So what happens is, if you can put one finger, two fingers, or three fingers between the front teeth, that gives you an idea of how wide an individual can open their mouths. Three fingers is actually quite wide. One finger, you can still do a whole host of stuff. And then less than that becomes much more of a problem. This particular individual also had some issues with swallowing and tongue thrusts, but would need fairly extensive treatment. Now, the issue then becomes, what do we do and how do we take care of this individual? For this particular individual, we would recommend extraction of all of those permanent first molars, all the remaining baby teeth, and to fix up as much as possible the other teeth in the mouth. And I'll talk a little bit later about what happens when we have individuals who have got complete closure, and which teeth do we recommend that they take out and why. But before I do that, I'm just going to cover very briefly a quick scoping review. Laura, I just want to check with you. How long do I have? Do I have another 15 minutes?
Oh, you absolutely do. This is an hour and a half, but we do want to go over your cases after, but keep on going. Very interesting.
Okay, thanks. So I'll need to rush it up a little bit. So I want to go over a quick scoping review that was done on limitations of jaw movements. It was done, there were 30 studies that were looked at, mostly case reports, and essentially what they found from the scoping review was that the age of onset of full ankylosis occurred in much older individuals when it was spontaneous, and if it was trauma-induced, when the individuals were much younger. Where the HO occurred also impacted on the amount of, or the maximum mouth opening in the front of the mouth with respect to where the HO would have occurred specifically in the arch form. So if you have a look at this in A, the coronoid process, which is on the mandibles right over here, and the zygoid process. And if you've got HO occurring between those, you can see how that's going to cause the maximum amount of closure and minimum amount of opening. The next was the masseter muscle, and the least amount of closure was when you had the HO in the mylohyoids and the platysma muscles, which is fortunate because HO often occurs in that submandibular area much earlier than it does in these other areas. So that's indeed was fortunate. So trauma-induced HO is significant with respect to closure, and spontaneous is older, and most individuals only start getting closure of their jaws in their 20s, which is really quite fortunate. However, there are cases where I have this young lady who has not even got all of her permanent teeth in yet. Those are all primary teeth. She was 4 years of age when she first had complete closure of her jaws. So obviously she has to be fed via a tube. She has a much harder time, and this kid is an absolutely delightful individual. And through her life now, it's going to be quite problematic with respect to what do we do and how do we do it. As she starts to lose some of those baby teeth, what are some of the things that we can do? So these are really impacts daily living in a way that is actually quite horrific. This individual was an individual from South Africa. The Tin Soldiers has made a movie of it. So I have no issue with, he's given us permission for his face to be on with that to be seen. And you can see it doesn't take a rocket scientist to see how bad his teeth are. Now, what's interesting is we made the recommendation. He had complete closure of his jaw and had not been able to open his mouth for the last 10 years or so. And we made the recommendation for him to have all of his teeth removed. And this was filmed, and the whole process was filmed, and you can access it through the Tin Soldiers. And the whole story can be accessed on Tin Soldiers, which is really quite remarkable. And we had all of his teeth removed under a very specific process. What is really interesting about Rian is that approximately 2 to 3 weeks after he had the teeth removed, I called him and asked him how he was, and he said that it was the most life-changing thing that had ever happened to him, having all of his teeth removed. It was the first time that he was able to lick his lips in 10 years. It was the first time that he was able to actually feel his lips, and it improved his eating. Now, a year later, last October, we saw him in South Africa, and I asked him again, and he said that he would actually make the recommendation to anybody who had complete closure to get their teeth removed because it has been such a life-changing occurrence for him. His demeanor, his skin, his health, his weight had all shifted absolutely dramatically. So every individual needs to be taken into concern individually. Doing surgery on individuals that have complete closure like this is complex. I would encourage you to have a look at the video, the session that Dr. Zvi Grunwald did with respect to what you do, how you do it. Every time I go to the surgery for individuals, and this is a young lady that we also had to remove all of her teeth due to the extent of the disease. So each time we go to the operating room with individuals like this, I think I do lose some hair, which is the reason why I have none at this point in time. But 2 weeks after this person had all of her teeth removed, I discussed it because she came in on a stretcher. She had no ability to move, and she actually had to be flown in by helicopter from Northern Ontario for us to do treatment for her. After 2 weeks, I spoke with her caregiver, and she said it's the first time she had actually begun to smile and talk in 5 years. So the impact on quality of life with respect to what happens in the mouth is extensive. This is the young lady that I had shown you the x-rays previously. And in terms of safety, I once again want to just bring this to the attention of you as medical professionals, because here's a person who went through all sorts of treatment, including removal of the HO in the left jaw. She had a prosthetic jaw replacement, which ended up triggering another HO event, which ended up having to be replaced. And she now has half of her jaw removed. It is moving all over the place. She cannot eat, she cannot open. And the surgery has resulted in something that is far worse than what she might have had she had nothing done in the first place. So what's interesting is that she went ahead and did this even though it was recommended not to. And the surgeons thought, well, they knew better, and we can just remove the HO and it's not going to be a problem. So as a practitioner, I'm not an oral surgeon, I'm a pediatric dentist. It really does cause me a lot of angst when I see these issues. So when we have a fully ankylosing jaw. So these are some of the questions that I end up getting from parents is, when should we plan on having a nasogastric tube, or when should we plan on having enteral feeding done, a feeding tube done, if an individual cannot open their mouth and cannot eat. And what is actually amazing is that, again, each individual needs to be taken into consideration based on their own personal and environmental domains, because there's some individuals that have the ability to eat a soft diet and live perfectly well, and others do not and need further intervention. So it's really hard to determine. Sometimes my colleague that used to do this prior to myself would take out the front teeth in order to make a hole for an individual to eat through, or to have any kind of emesis to throw up through. Personally, I remove the posterior teeth because I think the aesthetics in an individual is really important, and they have more than enough that they need to deal with. Again, it's a personal opinion, and it's important to give people choice. So care very much depends on the amount of mouth opening, of course. So if you've got full mouth opening, there's really no technical obstacles to providing care. The only thing that we need to do is that if the care is going to be complex, then the individual needs to be pre-medicated with prednisone prior to any kind of treatment. If it's not complex, like just a cleaning, they don't really need to be pre-medicated with prednisone. If, on the other hand, they are totally ankylosed and you're unable to see any of the teeth, the only possible approach to doing care is from a buccal or vestibular approach. And doing this becomes very much more complex. whether we're needing to fill the tooth or take the tooth out. So if we have a one finger opening, we can still do some treatment, but becomes much more complex. And so the importance of risk management in preventing disease from occurring in the first place becomes paramount. Does it impact the enamel of teeth? This is a 4-year-old boy. This does have FOP. And you can see the extent of the decay on those teeth. All those brown spots are decay. And you can even see the slight enamel aberrations that he has. So he does have slight enamel aberrations, although most of the literature doesn't identify that as something that happens in FOP. And this little boy was able to get full care done, not under general anesthetic, with just infiltration anesthesia, no mandibular blocks. And he was able to get a full mouth rehabilitation done, and is very happy for it, and hopefully will never get another cavity through the rest of his life. Now, one of the things that I want to bring to your attention is the importance of saliva with respect to risk and with development of decay. Many of the drugs that are used in FOP cause saliva to dry up, cause the saliva to be really much thicker, if you will, which makes for a lot of difficulty with individuals. So we need to be aware of the impact of the drugs, and then to prepare and promote the appropriate interventions for individuals with respect to how to make their quality of life better. And there are all sorts of things that we can do to improve that with respect to individuals and their saliva. I don't really have the time to go into the detail on that, but just to be aware that that's important to evaluate. So I get calls or letters from individuals almost 2 to 3 times a week. And here's one that I got just recently where the mom told me that the kid for the last night has had really thick saliva way back in the throat, notices in the morning, the tongue is swollen, and it makes it very hard for him to swallow. And so what to do about that, when to do it, when to intercede, and how do we make the quality of life for this individual better when we have those kinds of issues? So saliva is an essential part of oral health, and it's something that we need to be really familiar with. Cavities. What do we do about cavities? Can we fix cavities? Do we need to fix them? What do we do if we don't? This is an individual. You can see a cavity up in this area over here, and then a big one in the front tooth over here, this is your cavity over here, and this is the nerve of your tooth. And so it's starting to get very close to the nerve. And can you do nerve treatments? Can you fix that cavity? This is possible to do. Ideally, we don't want to, but it is possible. If we have to, there are methodologies that we can do as long as you can open the mouth. So again, it depends on environmental and personal conditions with respect to individuals. This young lady is really fairly young. She needs orthodontics. She's a mouth breather. She has very large tonsils. She can't really move her head and her neck because she's immobile, and she's got crowding of her upper teeth. What do we do, and how can we make her life any better? So sometimes we can do orthodontics. I'm going to go through some of that for you shortly. I oftentimes get this kind of a message from parents where they don't think that the dentist has the skill set to fix the teeth or the cavities. And in the guidelines, and I've got at the end of the presentation, you can actually go to the ICC website and you can download the full guidelines. The guidelines are fairly clear in terms of what to do, when to do, and how to do it. And we've recently updated the guidelines with respect to some of the things that can be done with cavities. And we don't always have to fix a hole, we can actually treat the hole pharmacologically with things like fluoride, specifically silver diamine fluoride, that will actually prevent that cavity from getting any worse. And so you can get in certain circumstances where cavities are not too large, and you can actually minimize the depth of where that cavity is going to go. So those are signs of where the cavities are. So I'm not going to go into the detail of this specific dental terminology here, but essentially a cavity occurs when you have what's called biofilm dysbiosis. Biofilm dysbiosis essentially is just where the bacteria in the mouth are such that they are much more cavity producing than cavity preventing. So we all have bacteria in our mouths. That's it's a given. So those of us who actually produce cavities have the bacteria that are more likely to do that, or more likely to produce acid. And those that do not have it are those of us who have bacteria that don't have that ability. And so the key piece with respect to dental care or oral health care in this population group is to take an individual from being dysbiotic, or from having an oral microbiome that causes a problem, to creating a microbiome that does not cause a problem. We have issues with aging. We have the development of wisdom teeth. We have the neck mobility issues. We have the difficulty of access. So these are all questions that come up for us to answer. So here you can see in that where the yellow lines show are teeth that are clearly impacted. On the other side, you're not noticing any impactions. So what do we do about those? Ideally, we don't want to wake the sleeping bear. So if you go in and you start to remove those teeth inappropriately, you might trigger an HO occurrence. So if we do that, if they're causing problems, then you obviously want to go in, because this issue here on this side could very well cause infection. We know infection can cause HO, so it becomes a real balancing act as to when you take them out and when you don't take them out. Again, the decision needs to be made on an individual basis, with the proviso that we don't wake the sleeping bear. Excuse me. So you can see how different individuals have very different manifestations. You can see how this person here has got teeth growing into really what we call ectopically erupting. Now, if this individual here has had any kind of HO, has got closure, removal of the teeth becomes really important with respect to being able to provide them some space for eating, some space for emesis, some space for taking pills. And so we would probably recommend taking out all these teeth here, these 3 back molars on this side, so that you have now a nice space for them to be able to get food in. And on this side, we would probably take out all of these teeth here, these 4 molars, even though they are healthy. Once you go in and you're doing a general anesthetic, which becomes a blind nasotracheal intubation, it's actually quite hairy, oftentimes requiring 2 anesthetists, an ENT surgeon, a couple of dentists. Once you go in to do the surgery, you want to do it so that you don't have to go in a second time. So working with pain and infected gums, inflamed gums, you can see that I'm following a relatively common theme here, the importance of maintaining really good health and good oral hygiene on an ongoing basis. There are always lots of issues in the mixed dentition or in the growing transitioning child. And these are things like which teeth do we take out? Do we take out the baby teeth? Do we take out permanent teeth to allow teeth to come in? These are all issues that become really important with the growing kid, and why it's so important for us to be able to see them on an ongoing basis. This is a young person that was sent to me from Turkey, actually. The issue here, you can see on the lower left-hand side, is how the permanent molar is caught up under the baby tooth and was causing major problems. And they needed to find someone to help them to do that. And so I will oftentimes speak to the dentist, speak them through the procedure, and identify to them what's a safe way to provide the care that they need to provide. And as long as the individual really doesn't have an ego and is willing to listen, we are able to take them through and provide the care that they need. Is orthodontics a possibility? Absolutely. And I'm going to give you a very quick, brief overview of some of the things that we have a look at in terms of orthodontics. So what you're having a look at is the amount of overjet, or the amount of teeth, the space that the front teeth project over the bottom teeth, which is called overjet. And then the amount of the teeth that cover the lower teeth, which is called the overbite. Now, what we normally recommend is that this here is not reduced like it would be in normal orthodontic treatment, because if you bring those teeth back, you're actually closing it up more like this. And you're eventually, if this child were to get full ankylosis, they would not be able to eat if that was closed. So you can get straightening of these teeth. Aesthetically, this is a kid who just was really hating himself. And you can see that's what he looked like. And this is what he looks like with full orthodontics. And so it was possible, his teeth were removed. And even though he's got fairly extensive mobility restrictions, he's a much happier kid today. As evidenced, you can actually see his gums are a whole lot healthier today than they were when he was first presented. Now, on the other hand, here's an individual with a very similar problem, but would we even consider doing braces on this individual? And again, you can see the decay already occurring. All these white lesions, the decay on these teeth. There is absolutely no way that we could recommend doing any kind of braces on an individual where the basic oral health was not being taken care of. But it does become a problem, because oftentimes the issue is the oral hygiene based on the problem that she is not feeling good about herself because nothing's being done? And if we were to do something, would she feel better about herself and then do a better job with her brushing? Engaging psychotherapists, social workers becomes a really important piece. I did mention swallowing earlier on. And the issue about swallowing is if we swallow incorrectly, if we have an aberrant swallow pattern, and every time we swallow, we're using the muscles of our platysma muscles and our tongue muscles and our accessory muscles. And we're swallowing, so it's more like that, where we're using those accessory muscles, and you build up anoxia in those muscles. What ends up happening with anoxia? You're getting HO. Then you're getting the bone in those areas, and becomes a major problem. So working with individuals to try and help them with saliva, to try and help them with their swallow pattern, becomes also important. So engaging in individuals, for example, that specialize in helping people change the way that they swallow, called myofunctional therapy, becomes something that we need to think about if people are able to do that. So this is a disease that really impacts families dramatically. I'm not going to go into the detail of it, but here's an individual whose parents were phenomenal in helping him and make utensils so that he could eat better. Now, what's interesting in this particular individual, and I promised Dr. Tosi that I would talk about it, is he was one of the individuals that went onto palovarotene. Canada was the first country that accepted palovarotene as one of the drugs that can be used. And he had trauma. He closed on his mouth closed down from, I believe it was 19 millimeters to about 10 millimeters. And then on the palovarotene and on prednisone, he actually opened back up again and he did not ankylose. So his was a success story. I do have other individuals where there were not success stories. That's completely different. And what's really interesting is the importance to allow individuals the possibility of self-individuation where they can live their life as they choose, as I spoke earlier. And here's an individual that has tattoos everywhere. And you would think that they wouldn't go ahead because it might cause infection or whatever. But we have to let people live the life that they need to live. So I'm getting close to finishing up here so that we can talk and present any other cases. What's important is the prevention of caries periodontal disease. We need to make sure that we don't cause any injuries from any dental care. We want to watch salivary testing. We want to do whatever we can to prevent the continuation and the development of decay. And we do have rinses that can be used to minimize that. The importance of continued radiographic controls is essential, especially if we have people who eventually get the neck immobilities that you cannot take the radiographs that we need. And, to really think about that, for those individuals who have full opening, we can do things in an appropriate manner. There are methodologies that can enable us to provide the care that we need to do. And anytime there's any complex therapy, the requirement of corticosteroid pre-medication, which is in the guidelines and can be evaluated. When we're looking at anesthesia, it's absolutely essential that mandibular block anesthesias are prohibited. Infiltration anesthesia is okay, and intrapulpal anesthesia is okay. And then, of course, general anesthesia, which becomes a much more complex process. In terms of general anesthesia, I would really encourage you to look at Dr. Zvi Grunwald's presentation because it is a complexity all of its own, but it does deserve a special team, including intensivists, including nursing, including your maxillofacial surgery, anesthesia, ENT. It becomes a real problem to work on individuals that have complete closure. So basic recommendations are prevention, or what I call risk management, managing the risk of getting a problem. Truthfully, it's impossible for us to prevent oral disease. We can only manage the risk of it becoming so. We want to get baseline metrics like maximum mouth opening, pulse oximetry, mobility restrictions. We want to prevent exceeding maximum mouth opening if we are doing any kind of treatment at any point in time from a safety perspective. You want to minimize the length of appointments. Again, you don't want to get anoxia or tiredness of the muscles. You want to reduce the jaw movements. You want to get less. So you want to prevent things like individuals eating lots of gum for long periods of time where they are overusing their musculature. You absolutely prohibit the use of mandibular block anesthesia. And is orthodontic treatment available? Yes, it absolutely is. Very briefly, palovarotene is the one drug which is available both in Canada and now in the United States. It is a molecule in the retinoid class. It represents the first drug so far specifically for decreasing UHO. I would encourage you to have a look at the ICC statement on palovarotene in the guidelines. The ICC have made a really good identification of what they believe the palovarotene and the drugs that are currently being used are useful for. And then the importance of prednisone and the complexity of prednisone. And I always consult with Dr. Kaplan with respect to some of the issues related to prednisone. And this was just one of the patients that we had that I'm not going to go through all of this with you because it's in more detail. And this is an issue that you folk are much more familiar with than I ever will be. So for further information and guidance, I encourage you to have a look at the treatment guidelines on the ICC website. And it's a good 120-page document that you can look up your particular area of expertise and you can see what is recommended for you. And then, of course, the IFOPA have extensive information on their website. So having done that, I might have gone over a little bit, Dr. Tosi. I apologize. Thank you very much for listening.